Critically ill children in some parts of Africa don't have very good chances. If they have a serious illness such as severe malaria, pneumonia or sepsis, then firstly they may have a very long way to go to their local hospital, and secondly, once they arrive, the equipment and treatments they receive there are limited, especially in comparison to what you would get in a paediatric intensive care unit in the UK. They will get antibiotics, antimalarials and blood transfusions if appropriate and put on a drip, but there are limited supportive therapies to treat the immediate critical state that they are in. The Fluid Expansion as Supportive Therapy, or FEAST trial, aimed to address this by researching whether an internationally accepted emergency treatment for children in shock used in the US and Europe could be given in hospitals in Africa to prevent children dying. The treatment involved giving fluids rapidly through an IV line to restore circulation and help improve perfusion, that's sort of getting your blood to the right places in your body, in order to correct the shock. The trial unexpectedly showed that this type of treatment was not suitable for children in these settings and led to many questions being asked about the trial, the treatment, and why this result occurred. My PhD aimed to address and answer some of these questions. The first was whether we could better prioritise children in general and what were the signs we should look out for. For example, heart rate, pulse, temperature, things like that. I developed a risk score, like a checklist of signs, so children could be assessed quickly by the nurses and so triaged appropriately, so those with lots of signs and a high score could be prioritised for treatment. I have also applied the score to other data sets and showed it worked successfully in similar settings. It could also be something developed into an app for a phone or a paper checklist to be used for triage in hospitals in Africa. The second question was whether I could identify a sign, something like heart rate, that worsened because of the fluid treatment and could help us explain why the treatment was harmful. That sign could also be something measured by researchers trying to replicate this trial in different settings. I also looked to see if there was anything we could identify that we were measuring that showed the fluid treatment was worse or better in certain groups of children, and whether that could help with explaining the mechanisms of the treatment. Finally, I looked at when the children were dying and were at highest risk of dying, and if that was different between those that had received the treatment and those that didn't. I found that those who had the fluid treatment were at higher risk for longer, and that mortality risk took longer to return to normal. I'm hopeful my findings will inform future research in critically ill children in these settings.